Hello everyone. Today's video is about asthma, as this topic has been requested frequently by folks. Now, first of all, this video has the big disclaimer of there are so many things we could discuss about asthma, and there's no way to get all of them into a short, concise video. So I'm going to try to go quickly and cover the most basic of topics about asthma. First of all, what is it? Well, not everything that wheezes is asthma. A good example of that is infants can get RSV bronchiolitis. There's another video of this, and it doesn't mean that they have asthma, even though they do make this wheezing sound when they're having difficulty breathing from this particular infection. And on the other hand, there's something called cough variant asthma, in which children don't wheeze, but they still have a form of asthma that does respond to the medicine for asthma, a bronchodilator called albuterol. The babies with RSV who are truly wheezing don't respond to that, which is partly why we think it's not true asthma. So most of the time, wheezing does go hand in hand with asthma. So let me explain to you briefly, simply, what wheezing is. This is how I think of it, and you know I like to oversimplify things because it makes it easier to understand and deal with. Wheezing is like whistling. If you were going to whistle, you would make air move through a tiny space. Right? You force air through a skinny spot and it makes a whistling sound. That's exactly what's happening with wheezing with asthma. So think of this as, now this makes all of it make sense. Two parts of asthma are bronchoconstriction. That's a circular smooth muscle around the airway that tightens up, and that's making that skinny spot. Now, the other component of asthma is inflammation inside the airway that can trigger that tightening up in the airway. And so the two parts of asthma are inflammation and bronchoconstriction, or tightening up around the airway, and that's what's making the wheezing. So when you think about asthma as having those two parts, tightening, bronchoconstriction, those circular smooth muscles around the airway squeezing, and inflammation, the lining of the airway, sort of think of it like the inside of your nose when you have a cold. It produces more mucus, it's puffy, it's red, it's inflamed. Those are the two parts of asthma. It makes sense when you think of the two kinds of medicine for asthma. For emergencies, or for a rescue medicine, we call it. The most common one is albuterol. It works immediately, but can be repeated every 4 to 6 hours. There are other versions that are extended release, used in patients who have a more severe form of asthma. But for the most part, albuterol is going to be the most commonly used emergency or rescue medicine for asthma. And it can be delivered in an inhaler, a metered dose inhaler. You'll hear us say MDI. And for those, we highly recommend using them with a spacer. Or it can be delivered in a nebulizer machine, in which case it comes in these little vials that you twist and squirt in, plug the machine in, and it turns the liquid into sort of an aerosol mist that the child breathes in with usually a face mask over their face. Let's talk about that spacer. So many patients, especially teenagers and even adults, think that they're too old to need a spacer, but studies demonstrate more medicine is delivered to the lungs where it needs to be delivered with the use of a spacer. So think about the emergency situation in asthma. A child could be symptomatic, coughing, wheezing, tighten their chest, short of breath, leaning forward or tripoding to get more air, all sorts of horrible things. You want the maximum medication delivery to the lungs that you can get. And so what happens is when you use your inhaler, and if you do it improperly, you just squirt the medicine on your tongue, and that doesn't get down to your smooth muscle circular around the airways that you need it to get to tell them to relax and open up so you can have improved air movement. So if you had a younger child, and often with infants we use the nebulizer machine with the face mask, but the trend these days is to use an inhaler with a spacer, because the spacers can also come with face masks that fit over their nose and mouth, so that whether their nose or mouth breathing, they'll still get the medicine in. So the way you would do that is always shake the inhaler, make sure if it's very first use that there's medicine in there, and then hook it up to the spacer. And then make sure you're forming a tight seal over the baby's nose and mouth with this face mask. Then you do one puff, and you count your baby's breathing 6 times. Then you give them 1 minute break, and then you place the face mask back on with the spacer and the bronchodilator, the rescue medicine. Give them one more puff, count 6 breaths, and then you're finished. And 2 puffs of medicine with the inhaler and the spacer is roughly equal to doing 1 nebulizer treatment with the nebulizer machine if you have one of those at home. So I also want to teach you about different levels of asthma. There is mild intermittent asthma, in which case the child only needs to use their inhaler or neb machine if they're having wheezing, and this wheezing is relatively rare. They don't have nighttime symptoms. They may only wheeze with a cold once or twice a year. I have a lot of parents say, my child doesn't really have asthma. They only wheeze when they're sick. That's still asthma. It's not normal to wheeze every time you catch a cold, and they should still have albuterol. If you are not sure whether or not you should give your child a nebulizer treatment or an inhaler, and you're on the fence about it, you think they might need it, just give it. Err on the side of giving the medicine if you're not sure, and then call your pediatrician and ask us for further guidance if necessary. So think about the medicines we were talking about. We've got the emergency bronchodilator to open up those tight spaces, but we've also got the whole other category of medicine is anti-inflammatories or steroids. Now, steroids can be used by mouth, orally, which means they give symptoms and relief possibly systemically or throughout the whole body. Now, the problem with that is steroids have a lot of side effects. And so many times if we have a patient who is more severe than just the mild intermittent, they're having nighttime symptoms, they're missing school from their asthma, or they're visiting the emergency department, or they're having several times of needing oral steroids for treatment of their flare-ups, then they need to be on a controller medicine, something that they take every single day, even when they're not sick, to reduce the inflammation. So instead of taking the steroid by mouth, basically controllers are just an inhaled steroid, and they also can be delivered via the nebulizer machine or the inhaler used with a spacer. And so the controller medicines are very important. A lot of parents are afraid to use them because they're afraid of the steroids going into their child. But understand this, the whole reason we want you to use them, if we recommend them and use them faithfully, is because then that will help prevent your child from needing to use the steroids by mouth orally that can have bigger long-term consequences, even including growth failure. So we talked about mild intermittent asthma, then there is mild persistent asthma, moderate persistent, and severe persistent asthma. Now, with the office where I work and with most pediatric offices, we want to see your child with mild intermittent asthma at least once a year. And most of the time, most of us at those visits, we would do an asthma control test, which is sort of a subjective assessment of how you feel your child's doing based on some questions you'll answer. Then we also, if the child's old enough and able to cooperate, which varies, it could be as young as 6 years, as old as 8 or 9 before they're able to, we would like to do something called spirometry, which is a form of pulmonary function testing to see how well your child's doing, because that's just more objective. Now, sometimes we have trouble with cooperation and effort, but if it's a really good effort, it can give us a lot of valuable information about how well controlled your child's asthma is. So we'll get from you the asthma control test, we'll administer the spirometry, we'll make a decision together, and then fill out something called an asthma action plan, or AAP. On the asthma action plan, there's a green zone for great, everything's going well, a yellow zone for caution, and a red zone for we are really in trouble here. And we will walk through with you what to do for these categories. If your child's persistent and on a daily controller, we'll list that under the green zone, because even though everything's fine, they're still supposed to use that medicine daily. But then when things start going downhill and we're having caution and we're in the yellow zone, there's cough, there's wheezing, there's chest tightness, there's shortness of breath, then we need to add in the emergency medicine. And then if we're in the red zone, your child is having great difficulty breathing, they can barely speak in full sentences, then that's the red zone, and we need to use 4 puffs on the albuterol inhaler, or even up to 2 vials in the nebulizer machine at that time for a true emergency, and you need to seek further medical assistance, of course, in that case, immediately. Now, I want to share a few other things with you. There are certain things you can do to help improve your child's chances of outgrowing asthma, which is usually what happens, you know, thank goodness. About roughly 2/3 of the time, children will outgrow their asthma, which is wonderful. Now, things you can do to help improve those odds are to strengthen their lungs, improve their lung function, get them out there exercising. It's fantastic for them. A lot of grandparents, your grandparents may even tell you, oh, that child can't participate in sports, they have asthma. Nothing could be further from the truth. If exercise does trigger some wheezing, that's okay. They can use 2 puffs of their rescue inhaler 10 to 15 minutes prior to exercise. Also, if you know what your child's triggers are, try to avoid them and try to control allergic triggers by using regularly your child's allergy medicine during their big seasons for triggering their allergies. So I hope that this has been helpful. I hope it explained to you the very basics of asthma. And I want you especially to hear, if your child's been told by your pediatrician to use a daily controller, or usually once to twice a day, Please be faithful with that. It's like wearing your seatbelt in the car so that if you run into trouble, your body's not thrown from the car. Those daily inhaled steroids don't do as much good when you're already thrown out of the car. You need your emergency medicine, your albuterol, but they help prevent any future attacks from being as frequent or as being severe when they do have them, and can help prevent further hospitalizations and further oral steroid use. So please be faithful in your control or use medication. Hope this has been helpful. Thanks.